During this lecture, we're going to cover the advanced life support algorithm and go through some of the pitfalls that you can experience during advanced life support. So life support is actually very easy. There's an algorithm written down for you, but it can be a very scary experience, especially if it's something you don't do every day. We need to embrace it can be scary. And always refer back to the algorithm, which should be on the wall of your clinics and resuscitation rooms at the hospital in case you become unstuck. When you first find a collapsed unconscious patient, you need to follow the basic life support algorithm, which we'll practice on the day. Without good quality basic life support, the patient won't survive. Once you get access to equipment, whether that be defibrillator and in a resuscitation environment or a resuscitation trolley, you can move on to your advanced life support algorithm. As with basic life support, you start CPR without delay and call for help and attach a defibrillator and assess the rhythm as soon as you can. Don't ever stop CPR for tasks such as attaching defibrillation pads, putting in IVs, intubation, etc. CPR, good quality, is always your priority, and we'll go over that in the forthcoming slides. Give people tasks. It's much better for you to be able to conduct an orchestra than be part of an orchestra. Allocate somebody to do CPR, allocate somebody to manage the airway, allocate somebody to manage access, allocate somebody for drugs, prescribing, etc. etc. Okay. What we see in front of us is the advanced life support algorithm for adults, as put out by the Australia and New Zealand Resuscitation Councils in 2010. Once you've done your basic life support and you have access to your advanced life support equipment, start at the top. CPR without delay, minimal interruptions. It's written here. 30 compressions to 2 breaths in an adult. Whilst you're doing this, get somebody to attach a defibrillator around you, turn it on, and look at the rhythm. Now at this stage, you can assess the rhythm, and there are shockable and non-shockable rhythms. If it is a shockable rhythm that you recognize, you shock the patient, you then go back to doing CPR, and you go around the loop. If you get to assessing the rhythm and it's a non-shockable rhythm, you do CPR for 2 minutes and you go around the loop. There are shockable rhythms, there are non-shockable rhythms. Along with all this, there are some drugs you can consider, adrenaline and amiodarone. We'll go further over the algorithm in due course and you'll get a chance to practice it on the day. I want to move on to the same algorithm for adults, same algorithm, I beg your pardon, for infants and children. There are a number of differences in the child algorithm. You'll notice now that during CPR it's 15 to 2, whereas it was 30 to 2 before. Still attach your defibrillator, still assess your rhythms. This time the shocks, if needed, are 4 joules per kilogram, and the adrenaline, if needed, is 10 micrograms per kilogram. They're the main differences for children. The CPR with 15 to 2, the shocks at 4 joules per kilo, adrenaline is at 10 micrograms per kilo. So with ALS, always remember, always CPR, 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 always CPR. Use the chart. Go back to the chart if you become unstuck. If you panic, if you're doing CPR and ventilating the patient, then you're temporarily sustaining their physiology until you can get better help. Okay, this slide looks at the differences between shockable and non-shockable rhythms. There is a lecture after this one which will show us the waveforms and how to recognize them. It's really not that difficult. You do CPR without delay, attach a defibrillator as soon as you can. As soon as you've attached the defibrillator, stop CPR and for 5 to 10 seconds check for a pulse and look at the rhythm on the defibrillator. There are 2 shockable rhythms, ventricular fibrillation or pulseless ventricular tachycardia. That's it. They are the only 2 rhythms that need a shock. If you identify either of these rhythms, you give a shock immediately and continue CPR immediately following that. After a 2-minute cycle therein, you stop and assess the rhythm again. If you see VF again, you shock it, and this time you give adrenaline. You go around another cycle. If you see VF again, this time you give amiodarone. And then you go around the cycle again. You give adrenaline every second cycle, and you give amiodarone on the third cycle. We'll get a chance to practice this on the day. For non-shockable rhythms, there is pulseless electrical activity, or PEA, and asystole. Either of these rhythms, you need to give adrenaline immediately and CPR immediately and reassess in 2 minutes' time. Let's go back to the adult ALS algorithm and run through those briefly. Okay, you find a collapsed patient. You check for danger, you check for response, you send for help. Immediately start CPR. 30 compressions to 2 breaths. Get as much help as you can. When the defibrillator arrives, continue CPR and attach the defibrillator around you doing CPR. Once the defibrillator is attached and turned on and the monitor is set to monitor through paddles, you then stop your CPR and check for a pulse. You need to stop CPR at this point because the electrical activity generated by you doing CPR and chest compressions will drive the monitor haywire and you won't be able to assess the underlying rhythm. Once you've assessed the underlying rhythm, in this particular case, we find ventricular fibrillation. The treatment for ventricular fibrillation is shock immediately. You charge the defibrillator to 200 joules, make sure that everybody is clear, you shock the patient. Immediately start CPR. 2 minutes is now counting down. In this 2 minutes, you need to continue good quality CPR. You drop some adrenaline because you may need adrenaline at the end of this cycle of CPR. When 1 minute 50 is reached, so your 2 minutes are almost over, you need to assess your rhythm once again. Stop CPR at 1 minute 50, charge your defibrillator, and then at 2 minutes, check the rhythm and see if it's shockable. If it's shockable, once again, VF, we go in shock. Immediately start CPR following this. Start thinking about your next 2 minutes. At the end of this cycle, you're going to have to give amiodarone. This is because our third shock is coming up. So you do 2 minutes. At 1 minute 50, you start charging the defib. Stop CPR at 2 minutes. Assess the rhythm. Ventricular fibrillation. Shock immediately. Back on CPR. Give amiodarone. You go around another 2 minutes, and so on and so forth. Okay, let's say you find a patient unconscious, and again, we'll start from the beginning. You do doctor's response, you send for help, you start CPR immediately. Start CPR immediately, get somebody to attach the defibrillator whilst you work. Turn the defibrillator on, turn the monitor to pads, and assess rhythm. Stop CPR, assess rhythm. This time you see asystole. Asystole is non-shockable. If you see asystole, you immediately start CPR again and give 1 milligram of adrenaline. Then you go round the loop. After 2 minutes, at 1 minute 50, you charge the defib, assess the rhythm. At 2 minutes, you look at the rhythm, you stop CPR, asystole. Dump the charge because it's non-shockable and move on to CPR again immediately. And you follow this loop round, giving adrenaline every second loop. So when you get to assessing rhythm, the shockable rhythms are VF and VT. The non-shockable rhythms are pulseless electrical activity and asystole. Same again in children, but remember 15 to 2 for the compressions, 4 joules per kilo for the shock, and adrenaline at 10 micrograms per kilo. Okay. Whilst you are working, whilst you're conducting your team, you should be thinking the 4 H's and the 4 T's of a cardiac arrest. Hypoxia, hypovolemia, hyper or hypokalemia and hyper or hypothermia, tension pneumothorax, tamponade, toxins, and thrombosis, cardiac or pulmonary. You can roughly categorize these into what one might call typical patients. For example, a pediatric arrest is often due to hypoxia, and that would be one of the H's that would need correcting. A patient with hemorrhage or an obstetric patient who arrests may be due to hypovolemia, and that would be corrected with fluids and blood products. A patient who is in renal failure might have hyperkalemia, and that could be corrected with calcium gluconate. A patient who has suffered a drowning may have hypoxia and hypothermia, or a patient who's been collapsed outside may have hypothermia and may need warming. A patient with trauma may have tension pneumothorax or a cardiac tamponade. You may see signs of IV drug use and signs of toxins abuse. And you may have a patient who's had a recent hip replacement, has a large swollen leg and a sudden collapse, and you might be thinking about a pulmonary embolus. Patients don't always neatly fit into these categories, but you can start thinking about it whilst you're working your advanced life support with the patient. Okay, just a few common pitfalls with advanced life support that we commonly see with people. The most common by far is the interruption of CPR. CPR gets interrupted because people get tired, people forget, people look at monitors, people get confused, people get very anxious. So make sure that good quality CPR is happening all the time. 30 to 2 for adults, 15 to 2 for children and infants. Get somebody to get the defibrillator for you as soon as possible. If the patient is in VF or VT, the only treatment for that is electricity and you will need a defibrillator. So get it early and attach it promptly. But of course don't stop CPR. Like an orchestra, like a conductor, you need to run the arrest. It's extremely difficult to run an arrest when you're intubating a patient, when you're putting an IV, even when you're doing CPR. You should be delegating tasks, airway, circulation, drugs, scribe, scout, so that people can work effectively as a team, and you should do as little or nothing as possible. Try and keep track of time, and a scribe is a good person to let you know when 1 minute 50 and when 2 minutes is coming, and how many cycles you've done, so you can keep track of your adrenaline and your amiodarone and all of your other medications. And of course, whilst you're working, think of your 4 H's and 4 T's. Now, at the end of all that, I accept that initially this flowchart and the pediatric flowchart look very complex and they sound very complex. It's difficult to learn in a lecture, but we will spend a lot of time going over this in the practical day, and it's actually not that hard. If you don't panic, you keep going with CPR, you refer to your chart. There's only 2 types of rhythm, shockable and non-shockable, and you run on a 2-minute cycle. There are only 2 drugs, and after a while you start to get a feel for it, and it's actually not as scary as it looks. Okay, I think we'll end there.